I have to thank MPIA for bringing me back to India. It's always a pleasure. I was at this conference 6 years ago in Bhubaneswar, and I always enjoy meeting new colleagues and traveling in India. So thank you so much for giving me the opportunity to be back. Today, I want to talk about one use of liquid biopsy, which is multi-cancer early detection. And I think this is a very important topic. It's really burgeoning and very actively discussed in molecular pathology circles, and I think it's important to talk about it because there's many nuances that people don't necessarily know about it. I'm a consultant, as I said, so for these are my disclosures and financial interest. Nothing that I'm going to discuss, I have any financial interest on it. And all the opinions that I have in this presentation are mine and mine only, and don't represent any organization that I work with. So I'm going to talk a little bit an introduction for those who are not that involved in liquid biopsy and how are we using it in cancer care. I see in the program there's several discussions about liquid biopsy, so this would be just one of them. I'll talk about how we're using liquid biopsy in early detection, and then look at multi-cancer detection, which is one of the promises that liquid biopsy can give us. And then I'll focus on the opportunities that this technology allows us to have, but also the perils and the things that we need to be thinking about and making sure that we address when we develop these technologies or when we get these technologies out into clinical use. So the first thing is, what's a liquid biopsy? I think most of us here know that, but it really is the ability to detect biomarkers that are being shed by cancer cells into the bloodstream. So we're not actually talking about cells in the bloodstream. We're measuring about DNA, RNA, protein biomarkers that are coming out of the cancer cells and go into the bloodstream. And we have new technology that allows us to actually measure them and identify that it is DNA coming from the blood, from the tumor, and determine if there is any abnormalities. So this technology allows us then to learn about the tumors that we couldn't learn before without actually having to do a tissue biopsy on them. Right now, one of the key factors here is that the ability to detect these biomarkers depends on several factors. Number one is the tumor burden. If there is very little tumor in the body, there will be very little shedding of these molecular features in the bloodstream. The abundance of the molecular marker in the tumor is also important. So if it is in all tumor cells or it's only in a clone of the tumor cells also matters to whether we can detect it. The shedding rate, not all tumors shed DNA or RNA equally. Some tumors are much more active. Generally, those tumors that have much more cellular regeneration will actually shed more DNA, but that's not necessarily a correlation. And then the stability of the biomarker in the blood. Of course, if it's RNA, it is not going to be as stable in blood as DNA is, for example. So many of us use DNA in this. So there's many factors to consider, and which is important because it means that we can't use the same formula for every cancer. And this is very, very important to remember. So how do we use liquid biopsy in patient care? And again, I'm going to focus really only in the very beginning here in cancer detection, actually screening and early diagnosis. But of course, we know liquid biopsy is being used for molecular profiling of tumors and determining, what the molecular characteristics they have, deciding treatment, monitoring those tumors after therapy, or monitoring the response, and then monitoring that clonal evolution and deciding how we're going to treat those. But again, we're going to focus on the early detection, the very, very early part of these, that we do. And this is important because mostly us as pathologists, we don't necessarily get involved in this. We do screening in our labs. We have a talk after me talking about HPV and some of the screening, cervical cancer screening that we do in our laboratories, but we're not necessarily that involved into, population-wide screening efforts. And this is really what we're talking about. Now, why is early detection important in cancer? I don't think I have to convince all of you that this is very, very important. Early survival is directly related to cancer stage at diagnosis. We know if you are diagnosed with a stage 1 cancer, your opportunity for survival is much better than if you're diagnosed with a late stage cancer. And that's mainly because we do have curative options for early stage diagnosis, right? So we have already shown that with using, early detection, we can actually reduce cancer mortality. That's already shown. I won't go into those examples because that is something that we already know how to do. Now, why is liquid biopsy an opportunity here, and what can we do with liquid biopsy? And I get giddy here because it's really exciting to see the technology coming to a place where we can actually do things like shifting the stage curve to the left. What that means is, in that curve those graphs that I show, increasing the numbers of early stage diagnosis. If we do that, we will for sure impact mortality. Increase the detection of pre-malignant lesions, meaning reducing the number of cancer diagnoses. That has happened already worldwide, for example, in cervical cancer. We have reduced cervical cancer, the incidence, very, very low, because we detect the pre-malignant lesions before they become cancer. Another big opportunity we have with liquid biopsy, and I think this is probably one of the biggest ones, is to expand access for early detection. Most of our programs for early detection actually have limited ability to be expanded. Pap smears actually have been expanded out into community, but you still have to, go to the doctor. The sample needs to go to the pathology laboratory. There is a lot of work that needs to happen, and blood collection is an easily deployable tool to actually get screening out there in the population. And then, one thing that I wish we were doing more in liquid biopsy is to improve the ability to monitor patients that have increased risk, either by hereditary or by environmental, right? We all know, for example, people with high risk, what we do is we survey them. We might do imaging. Sometimes we do surgery on them, but it would be great if we could actually just follow them with a liquid biopsy and only do surgery when needed, right? Not as a preventative, but do surgery when the tumor is there and be able to do that. So that would be, to me, one of the holy grails of what we can achieve with liquid biopsy. And then the last one, which is really where I'm going here, is to be able to detect multiple cancers with a single test, right? Instead of have different programs for screening, we could potentially have one program for screening for all cancers, right? That is, as I'm going to go in a little bit, easier said than done, because there's many steps that we need to do to get to that opportunity, and it's not going to be easy. Let's focus a little bit on the approaches of early detection with liquid biopsy. So as I mentioned, you can do two different things. If we focus on the target, you could do multi-cancer, meaning multiple tumors at the same time, or you could do specific cancer screening with early with liquid biopsy. You can focus in different types of populations, as shown here, with the ultimate goal, of course, of getting to the general population. And then there's different technologies that you can use, which each offer their advantages and disadvantages. So some of the technical approaches that are being used currently is, for example, fragmentomics. And this is a little bit related to Dr. Bloch's talk, because what we're looking here is at the chromosomal breakage patterns. And this really at the level of the DNA, in between the histones. And basically, because of the methylation that happens in tumors, the DNA breaks differently in tumor cells versus normal cells. Not only that, it breaks differently between melanoma and colon cancer and lung cancer. So you can actually learn a lot from that tumor, and that allows us to actually detect those fragments in the blood and classify whether that patient has a tumor and where that tumor is coming from. We're also using, and this is probably the most used technique, which is methylation profiling, similar to what I just said on fragmentomics. Methylation profiles are different between different tumor types, between different cancer cells, and between different cancer and normal. And most of the newer ones are actually using combination of those markers. Look at an aneuploidy as measured by the NGS approach, using this looking at the nucleic acids in the blood, proteins, methylation and mutations, as I mentioned. Here's another group using, for example, methylation and fragmentation together to actually boost the ability to detect the cancer signals in the blood. And this is probably where it's going to go, although some of the actually available tests now are with a single biomarker. Now, let's talk about some of the laboratory challenges, and then we're going to talk about some of the performance challenges in this test. So I think these are things that we know as diagnosticians, people who work in the laboratory. We know these concepts, but bringing these concepts out to screening is a little bit different. So what important factors we need to pay attention? So specificity. This is probably the most important factor for a screening test. Why? Because especially in screening for cancer, a false positive can do a lot of harm, right? Because the diagnostic odyssey that we're going to subject to that patient to go, because we tell them you might have cancer, and then you have to do a lot of stuff to determine whether that patient truly has cancer or not. So we want to be very, very sure. And I'm going to go deeper into this concept of why this is super important. Then sensitivity, of course, is very, very important. We want to identify as many as we can. It is not worth putting out a screening program out there if the sensitivity is low, right? Sometimes it is, depending on the morbidity and the mortality, but it's important to keep in mind that we want to be able to maximize as many people as we can. Patient accessibility, I already mentioned this. We do have screening tools out there for certain cancers. Lung cancer is one of them, where we use a type of computed tomography called low-dose CT. But the problem is it doesn't reach everyone in the population. And in the United States, since they started that program, only about 15% of individuals that should be screened are being screened. And therefore, the impact of that program is extremely limited, right? And the other part is cost, right? We need to be mindful that for something to be deployed in a large population, it cannot be hundreds or thousands of dollars of cost, right? And I think that, we're all here, as mentioned, I come from Mexico, so we all know that we work in countries with limited resources, and this becomes a tremendously important issue. Now, what are the challenges regarding, when we think about the use of these technologies in multi-cancer early detection? Well, the first one is when we say multi-cancer early detection, we're really talking about detecting multiple different diseases. And the benefit of the screening might not be the same for all these cancers, and the potential also are very different for each of these cancers, the potential for harms. We do need to define what is the at-risk population. Screening in open populations, it's tremendously expensive. So usually we start with what we call at-risk populations. We need to be able to have a confirmatory procedure or test that to be able to say, well, the test says that you might have cancer, we need to have something to confirm that that patient has cancer, and that doesn't exist for all cancers. The analytical requirements for early detection are likely to be different for each cancer type, and then the validation, because of these issues, will require very large cohorts. Let's tackle each of these a little bit further. So talk about cancer screening. In the United States, we actually have cancer for screening for 4 cancers. I'm not including cervical cancer here, but what's important here to show is, number one, we have different degrees of recommendation. So colon cancer, for example, we know it's good. We know it's easy to do. We have tests for confirmation that are very easy to do, and we have a very high negative predictive value. So if we say you don't have colon cancer, the chances that you have colon cancer are tremendously low, right? But then even with the others that we do, you see that recommendations don't achieve a very high degree because there is a lot of potential for harm. Also because the confirmation might require an invasive procedure. So it is very different what the type of requirements we have. So this is one thing. So you can see here how for colorectal cancer, for example, the requirements are different, right? And the target test requirement, for example, would be a high NPV, when in breast cancer, we actually want a high PPV, and a lot of that has to do with the harm that we can potentially do. The same for ovarian cancer. So we can't really design a test that is actually, addresses the needs for each cancer individually. When we start thinking about it, we really need to focus a lot into these at-risk populations. How do we define the at-risk populations? So this is essential to the performance of a screening test. And you can see here the recommended population screening by the U.S. Preventive Task Force. And you can see, very well-defined groups, those groups that we know are at high risk for those diseases, right? But you can also see that those groups are not necessarily overlapping, right? So when we're saying that we want to do multi-cancer early detection as a screening tool, right, we can't really say, because these populations, if we are having a pan-cancer test, we need to get the widest population available that also includes all of these populations. So that becomes a tremendous challenge to actually develop a test that can actually, have a widespread applicability in multiple different at-risk populations. And when we start looking into areas where we don't have yet good screening technologies, now it becomes a very difficult issue to decide who are we going to screen for pancreatic cancer. We know pancreatitis increases the risk, but the risk is actually tremendously low. We know, who do we screen for stomach cancer? Those that have positive H. pylori, those that have gastroesophageal reflux, and so on. We don't really have good populations with high enough risk. Once we go beyond those four cancers to actually know what is the at-risk population. So in many of these cases, we might actually want to start with very high-risk populations rather than just high-risk populations. Let's move to confirmatory test and procedure, because then again, that helps us also define how we're going to do this. And this is very important. For these is where I was talking about the positive predictive value. And this is something that we really don't learn a lot in pathology, but the positive predictive value is dependent on the incidence of disease. Meaning, if you have a test with established sensitivity and specificity, and you apply that test to someone, to a disease with low prevalence, your positive predictive value is going to go down. And if it's high prevalence, your positive predictive value is going to go high. This is a table that was developed by a colleague, Taryn Hall, which is looking at the overall sensitivity for each of the tumors included into one of these multi-cancer early detection tests. And then looking actually at the age of the group ages, and you can see that even when the sensitivity is very high of the test, well, not very high, but decent, let's say 40% sensitivity for these tests, your PPV for the great majority of tumors that you're looking in this is very, very, very low, less than 1%, meaning the great majority of positive results that we're going to see from a test like this being done in the open population is going to lead to false positives. Basically, the great majority of these results are going to be false positives, right? So this is very, very important, because then what we're going to do with those patients is, subject them to a diagnostic program to determine if they have tumor or not. But we know the great majority of them are going to be negative, are not going to have tumor, even though the test actually says is when. Let's walk through a few examples here, and I'll try to do these quickly. But this is, again, the sensitivity for different tumor types for one of the commercial tests out there. And you can see these are the ones that require screening. We can see even in tumors with screening, we actually have very, very low performance of the test. And some are actually better than others. But let's just look at a few examples here. If we look at prostate, this is one of the highest ones with a positive predictive value of 17%, which means 83% of the results are negative, right? Are actually false positives, right? And the workup for these is undergoing either ultrasound or MRI, which we can't afford to do on everyone, and biopsies on these patients, right? The same happens to if we look at liver with a positive predictive value of about 0.2%, kidney with a positive predictive value less than 1%, or ovary with a positive predictive value of about half of 1%. And again, in this, I'm taking the positive predictive value that is the highest for an age group. So this doesn't apply to every age group. It's really for that age group in which I have the highest positive predictive value. So, most cancers that we include in this multi-cancer early detection test would require a diagnostic workup that includes imaging and an invasive procedure, either endoscopy or surgery to do that. And we can't afford to do that if most patients are going to be false positives. So this is actually really, really important to think about. Then how do we design a test that actually is able to detect multiple different cancers, and more importantly than that, different stages of those cancers? One of the key factors that we are finding, and this is really, until we started doing this, we really didn't understand this as well, is that biomarkers for early cancers might not be the same ones as the biomarkers for late cancer, right? What helps us detect a stage 4 cancer, is not the same biomarker that helps us detect colorectal adenoma with high-grade dysplasia. These are different biological signatures that reflect the evolution of the cancer at the time. So a test that performs well in stage 4 or 3 cancer doesn't necessarily perform well at stage 1 or 2 cancer, or even pre-malignant lesions. You can see here, for example, this is another of the tests available there, and you can see the performance, actually, the sensitivity for the test at different stages, and you can see how the test is actually fairly decent at detecting stage 3 and 4, but the performance at stage 1 cancers, which is really what we actually want to detect, is not as good. This is another example for one of the other tests. You can see here, I think this is a very telling graph, how the sensitivity in stage 1 for almost every tumor that you see, actually, some are much better than others, but you can see here in lung, you can see here in esophagus, the sensitivity for stage 1 cancers, which is really why we're deploying these, right? We want to identify those early stage cancers, is actually very, very low, right? So it's very difficult to define, because we need to address those biomarkers that helps us pick stage 1 tumors, as well as those that helps us pick stage 4 tumors, or late versus early stage. There are some efforts out there. Actually, some groups are targeting, are doing early cancer detection, targeting single tumors, not trying to do multi-cancer early detection, but actually looking at single tumors. And these are some examples of those groups. And you can see that in many of them, actually, they're getting better detection of stage 1, still not as good as stage 3 and 4, but they're actually getting better. And inclusive, this group reported about 50% sensitivity for pre-cancerous lesion for advanced adenomas. This is in liquid biopsy. Remember, so we're actually being able, in some of these cases, to detect a pre-cancerous lesion, the signatures of those pre-cancerous lesions in the bloodstream of patients with them. But again, these can only be achieved at this moment with looking at targeted assays, at looking at one cancer at a time. Now, maybe the approach here is actually to develop these individual tests that we can then deploy at overlapping groups of population. That might actually be something that we can do. The last challenge I'm going to talk is how big the studies, and this is really something that we're not used to do in pathology, but just the sheer number of participants. This is one of the studies, the study to actually do the analytical validation of one of the tests commercially available. They use 15,000 patients to be able to actually look at that. And the problem with this study is that it is a multi-cancer detection. So when you start looking at the actual number of breast cancers, colon cancers, lung cancers, you start getting into very, very, very little numbers. And this is why it requires a very large studies. Here's one example of the studies focusing on lung, just for a lung cancer detection, early detection, which is one of the most promising areas, because we already, as I mentioned, we already have screening programs. We know the screening programs are not performing very well. We know for certain how well we can decrease mortality of patients with lung cancer. But you can see that to actually just look at validated the clinical performance of these tests, we are talking about 15,000 patients just for colon cancer, for lung cancer. And this is a disease with a fairly high prevalence, which means, we only need 15,000 patients, right? If we're doing disease with lower prevalence, now we need hundreds of thousands of patients. But you can see here, this is the study being done with the NHS in collaboration with GRAIL to actually evaluate their platform. I wouldn't say validate, but evaluate their platform on the British population, and they're targeting 140,000 patients. This is huge, right? And I can tell you already, they're probably not going to have enough of every cancer to actually verify the performance of all the tests in all the cancers. And already ongoing studies or soon to be started studies in colorectal cancer are about 12 to 15,000 patients to be able to do that. And we know that because we already have tests for screening with colorectal cancer, and that's the type of size of studies that we need. So I'm going to conclude here saying that, it really, really is super exciting that we have technology that allows us to develop tests with for early diagnosis of cancer. And, but it's important that we do it responsibly, that we don't just rush and put these technologies out there because we need to look at how they're done. Most of the studies that have been done are case control studies, let's say by necessity, because we need to supplement, the cases in a population cohort with cancers, because the incidence is low, especially of early stage cancers. And in many cases, we can't even get the early stage cancers, right? Pancreatic cancer, it's very hard. How can we get samples of patients with early stage pancreatic cancer so we can actually identify what are the biomarkers for pancreatic cancer at the early stage? It's almost impossible. It's very, very hard to do. So those are things that we need to think about. The true performance of this test in the intended use population is what we need to think about, and it has not been demonstrated. We have to be careful about harms, right? We think that, there is no harm for a diagnostic test, but there is if there is a surgical or an intervention that is going to happen after that diagnostic test. And it's our responsibility to make sure that that doesn't harm people. We do have strategies, as I mentioned, targeted early detection tests seem to improve specificity and actually have better positive predictive values compared with others. So this could be a strategy where we could actually, develop individual tests, a test for lung, a test for colon, a test, and then we can pull those together and use them in the appropriate population for actually doing multi-cancer early detection. Also, repeat testing might actually be something we need to think about, right? Does it one positive result? We probably should do nothing. 2 positive results, 3 positive results, maybe actually is something that we would need. But this is an ongoing field. Studies are happening. We are going to see these published, and it's super exciting. I do think that in the future we will be able to deploy these tools to reduce the incidence of cancer, to shift that curve and allow for more early detection. But we need to do it responsibly, and I think it's tremendously excited to see where we are today and where we can be tomorrow. So with that, I'll stop here and I'll take questions if there's any.